Welcome, everyone. Today, we're diving into a really powerful imaging technique that lets us peek inside some of the body's most delicate and intricate plumbing, and we can do it all without making a single incision. We are, of course, talking about magnetic resonance cholangiopancreatography, or as you'll hear it called, MRCP.
So that's the big question, right? How in the world do we map out this tiny, complex network of biliary and pancreatic ducts completely non-invasively? Well, the answer is pretty elegant, and it all comes down to the physics of MRI.
Okay, so here's the secret sauce. MRCP uses what we call heavily T2-weighted sequences. Now, what does that mean in plain English? It basically tells the MRI scanner to make things with static fluid, like the bile just sitting in these ducts, shine incredibly bright. And at the exact same time, it tells all the surrounding organs and tissues to go dark. The result? You get this amazing, high-contrast roadmap of the entire system. It's fantastic. So here's our game plan for this explainer. First, we'll open up the MRCP toolkit to see how this scan is actually done. Then we'll lay out the anatomical roadmap covering what's normal and what's not. From there, we'll go on a few key clinical missions to see how MRCP solves real diagnostic puzzles. We'll also navigate the interpretation obstacle course to avoid common mistakes, and then we'll wrap it all up with the big takeaways. All right, let's start with our toolkit. This is all about the nuts and bolts, the practical side of things. How do we prep the patient, and what specific sequences do we use to get these incredible pictures?
The prep is actually pretty simple, but it's absolutely vital. We have patients fast for about 4 hours. And there are 3 big reasons for this. It calms down the stomach and bowels so they don't create motion artifact, and, just as important, it lets the gallbladder fill right up with bile, making it pop on the images. Once we're ready to scan, we lean on a few key sequences, mostly quick breath hold scans and some longer, super high-resolution scans that are timed with the patient's breathing.
Let's break those down. You can think of the 2D haste as our scout image. It's super fast and gives us a quick lay of the land. Now, the star of the show is really the 3D fast spin echo, or FSE. This one gives us those gorgeous high-res thin slices that we can rebuild in any direction we want. And finally, you've got the thick slab haste. That gives you that classic all-in-one picture of the whole ductal system, which is perfect for getting oriented quickly.
Now, we can even take MRCP to the next level and turn it from a static picture into a functional study, one that shows us how the system is actually working. We can do this by injecting secretin, which is a hormone that tells the pancreas to get to work, and this shows it perfectly. Look on the left, that's our baseline. Then, just 3 minutes after the injection, you can see the pancreatic duct widen as it starts pumping out fluid, and by 9 minutes, it's right back to normal. This is a great way to assess function and even unmask some subtle problems.
All right, time to pull out our anatomical roadmap. You see, before you can ever hope to spot what's wrong, you have to know inside and out what right looks like. So this section is all about building that solid foundation of the normal anatomy and its most important variations. And here is our reference map. This is what we're looking for. You can see that bright pear-shaped gallbladder labeled GB. If you follow the pipes down, you can see the common bile duct, that's the short arrow, heading towards the small intestine. And then running right across the middle, marked with the arrowheads, is the main pancreatic duct. Getting comfortable with this view is step number 1.
Okay, now for some really high-yield numbers that every trainee just has to memorize. It's a simple rule of thumb. For the ducts inside the liver and the main pancreatic duct, they shouldn't be bigger than 3 millimeters. The common bile duct outside the liver gets a little more room, up to 7 millimeters. Oh, and a key exception. If a patient has had their gallbladder removed, that common bile duct can relax and widen up to 10 millimeters and still be totally normal.
So, we have our map, we have our measurements, but here's the fascinating part. What we call normal anatomy is only what you see in about 60% of the population. Everyone else has anatomical variants, and knowing what they are is absolutely essential. Just look at this comparison. On the left, you've got our standard setup, but look at the image on the right. This is called pancreas divisum, and it's the most common variant of the pancreas. Basically, the 2 parts of the pancreatic duct failed to fuse during development, so they drained separately. That main duct, labeled P, drains into a different spot. And this isn't just trivia, it's clinically important because it can increase a person's risk for pancreatitis. And here's another variant that is just critical to spot, this time in the biliary tree. That arrow is pointing to a duct from the right side of the liver that takes a wrong turn and drains into the left hepatic duct. Now, why does that matter so much? Well, imagine a surgeon is planning to remove the left lobe of the liver. If they don't know about this variant, they could accidentally tie off this duct, which would block off drainage from a whole section of the right lobe.
Finding this on a pre-op MRCP can literally prevent a major surgical complication.
So now that we've got our bearings and we know the lay of the land, let's go on a few clinical missions. This is where the rubber meets the road, where we see MRCP acting as this amazing, non-invasive detective, sniffing out a whole range of diseases.
Mission number 1. Find the stone. This is a textbook case of what we call choledocholithiasis. You see that bright signal from the bile? Well, the gallstone sticks out like a sore thumb. It's that distinct, dark filling defect right where the arrow is pointing. MRCP is so good at this, it can spot stones that are just a couple of millimeters in size.
Next up, we're on the hunt for a malignant blockage. Check out the image on the left, that 3D style view. You can see there's a big problem right where the bile ducts exit the liver. The ducts are wide, but they just stop. They don't connect. The image on the right, which is a standard slice, shows us the culprit. That bright mass right there is the tumor causing the whole mass. Now this is another one of those classic signs you see in radiology. The arrows here are pointing to two dilated tubes running side by side. That's the common bile duct and the main pancreatic duct. We call this the double duct sign. And when you see it, it's a huge red flag for a mass in the head of the pancreas that's blocking both ducts at the same time. This image shows us a chronic inflammatory disease called primary sclerosing cholangitis, or PSC. You'll notice the ducts don't look smooth at all. Instead, you've got these multiple short narrowings with little areas of dilatation in between. It gives the ducts this very characteristic beaded appearance, which is a total hallmark of PSC on MRCP.
And finally, MRCP is absolutely essential for sorting out cystic tumors in the pancreas. This table is a great little cheat sheet. Serous cystadenomas tend to look like a cluster of tiny grapes and are almost always benign. Mucinous tumors, on the other hand, have larger cysts, and they have a pretty significant potential to be malignant. And then you have IPMNs, which connect to the duct system itself. The ones involving the main duct carry a really high risk of becoming cancerous.
Okay, so we've seen all the amazing things MRCP can do, but now it's time to tackle the obstacle course. Because knowing the common pitfalls, the things that can trick you, is just as important as knowing the diseases. This is how you really build confidence as an interpreter.
Pitfall number 1, and this is a big one. Do not rely only on the pretty 3D pictures. On the left, that reconstructed view makes it look like there might be one little filling defect. But look at the original, thin-sliced source image on the right. Whoa! It clearly shows multiple little stones. This is a crucial lesson. Reconstructions can average things out and hide details. You have to always go back and look at the source images.
And here's another perfect example. The 3D image on the left seems to show a narrowing, a stricture in the hepatic duct. But something's fishy. There's no backup of fluid upstream. The thin slice image on the right solves the puzzle. You can see this little dark line crossing over the duct. You know what that is? It's the right hepatic artery just pressing on the duct from the outside. It's a pseudostricture, not a real one, a classic mimic.
And finally, let's talk about pitfalls you can find inside the duct. The arrow is pointing to a dark spot right in the middle of the bile duct. Your first thought might be stone, but hold on. In a really dilated duct, the bile doesn't just sit there, it can swirl around a bit, and that turbulence can cause a signal loss that looks just like a stone. It's a flow artifact. Other things to watch for are air bubbles, which will float, unlike stones which sink.
So there you have it. We've journeyed from the basic how it works of MRCP all the way to its clinical missions and the tricky obstacles you might face. We've built our toolkit, and we've charted our anatomical map. The real beauty of this technique is its power to give us crystal clear answers without ever being invasive, and that really changes things for patients. So the only question left is, now that you have this roadmap, what hidden pathologies will you be the first to uncover? Thanks for joining me.